So I'll try and give you my way of looking at this with a little bit of personal experience, some data. It's always good to have some data. I want to go over what defines a good indication, some of the unique advantages of EUS. I want to focus on the best indications, but I also want to focus on what I'm finding with as time goes on, what are some very weak indications, which may surprise you. And then quickly over EUS guided biopsy, and then a little bit on therapy if I have time. And I don't want to overlap with the other talks that I've seen are coming up. So what is a good indication? Well, I think it always has to be a situation where the benefits of the procedure outweigh the risks, which is not too difficult with EUS. It's pretty safe. And even when we do interventional EUS and biopsies and things like that, if we're careful, really the risks generally are much less than the benefits. I think it should provide unique information, particularly unique information that can't be obtained with a less invasive procedure. However, EUS, in my opinion, is not that invasive. Just putting somebody, to sleep and then putting a scope down like a G-scope. Now they're small scopes. It's very safe. It's very quick. And I think to some extent, the sedation now for EUS makes, for example, doing an EUS less unpleasant than, for example, having an MRI. I don't know if you ever had an MRI in your life, but it's not fun to have an MRI. At least the EUS, they can't remember. And then it should change, well, should it change management? The thing is, a lot of studies looking at the impact of EUS look at changes in management. The problem is, a test can change management, but it can change it into the wrong direction. So changing management in itself is not a great outcome, if you ask me. It should actually improve clinical outcomes. So the changes in management should actually make the patient do better. That's a better variable to look at in the end. Now, there's some easy outcomes, there's harder outcomes, and there's soft outcomes. So, if you're doing therapy now and you drain the bile duct and the bilirubin goes down, that's a pretty hard, easy outcome. But with imaging, sometimes the outcomes that we're looking at are softer. So some people will say, well, EUS, how does EUS improve the outcome of pancreatic cancer? Well, nothing really improves the outcome of pancreatic cancer that much. But a softer outcome is getting a diagnosis more quickly, less painfully. Those are softer outcomes that I do think benefit patients that may be hard to measure. So what are the unique advantages of EUS? So these are from the early days of EUS. It was originally designed to do T-staging of luminal cancers, and we would get these amazing images here of high frequency ultrasound probes showing the definition we can get. This is something definitely you can't really get that well with other procedures. MRI is actually not that bad. I'll show you for rectal cancer. And then I think the primary benefit for me is that EUS gives you this really unparalleled access to the pancreas via obviously the stomach. So you get the endoscopy, including a view of the papilla, which is very important for pancreatic disease. You get a view of the parenchyma. You get a view of all the ducts, but you don't just get a view of the inside of the ducts like with the RCP. You get the lumen, you get the actual wall of the duct, and you get outside the duct, which is something you really don't get with any other procedure. You get the relationship with the vascular structures, which is obviously very important for tumor staging. And you have access basically to biopsy anything you can see from all these structures. And then you also get this really high resolution imagery of the bile duct, up to the hilum anyway, the cystic duct, the gallbladder. I think there is an advantage in fat people to see the gallbladder. It hasn't really been shown, but I think that's true. We can see things now that ERCP can't see, for example, sludge. And again, we get this excellent view of the papilla. And it's definitely more sensitive than MRCP for small bile duct stones. But I think the unique thing that will keep EUS around for years to come is the ability to combine this high-resolution imaging safely, but with tissue acquisition. And I don't care how good imaging becomes, until we no longer care about getting pathology. I still think this ability to get tissue where you can't get it percutaneously without the risk of tumor seeding and bleeding, all kinds of stuff, this is what will keep EUS around for years to come. So what are the best EUS GI indications? I split them into, based on sort of what I see most in my practice, suspected pancreatic biliary disease, but there's two groups. There's the CT negative and the CT positive group, and then non-pancreatic biliary, so SMT, suspected linitis, indeterminate strictures, liver disease, and sort of the anal stuff. And I'm not going to go into a lot of detail on all of them, but I'll try to give you what I think is most important. So CT negative pancreatic biliary disease is things like idiopathic pancreatitis, diagnosing or excluding chronic pancreatitis. I think there's a little bit of controversy about EUS and chronic pancreatitis. I'll try and simplify that a little bit. Diagnosing or excluding divisum, diagnosing or excluding bile duct stones or sludge, or gallbladder stones and sludge. CT negative jaundice, this is usually in the liver patients who they send to us who are deeply jaundiced, and they want to make sure there's no bile duct stone. I will tell you one of the strongest predictors of negative EUS is referral from hepatology. I don't know if that's your experience, but it's this very strong predictor. And then localization of neuroendocrine tumors. So this is just a study we did many years ago about the yield of EUS for idiopathic pancreatitis, either after the first episode or the second episode. And it just showed that we can see things. For example, these are patients who had negative CT and negative percutaneous ultrasound. And we found, for example, gallbladder sludge in a fairly significant amount of people. We found, obviously, chronic pancreatitis, which some people don't believe exists, really. But we found that in a certain number of people. But basically, we were able to find a cause in about 1/3 of patients in whom the previous imaging didn't show a cause. So I think EUS really remains the only test that can go further than what you've got with CT and percutaneous ultrasound. You certainly don't want to do ERCP as a primary test in these people. For chronic pancreatitis, again, I think there's a lot of controversy about, people think EUS overcalls chronic pancreatitis. I think if you know how to use the criteria properly, you won't overcall chronic pancreatitis. But I do think that the thing people miss is that the primary benefit of EUS, I think, is actually excluding chronic pancreatitis. So if you think EUS sees too much chronic pancreatitis, if your EUS is normal, you've basically excluded chronic pancreatitis, which may be important in patients with unexplained abdominal pain. So when the EUS is normal, we're talking about less than 2 criteria. We know these are people who in studies have had no history of pancreatic disease, don't drink, and in whom ERCP is normal. I think you can exclude chronic pancreatitis. My slides are going by themselves. And then when it's very, very abnormal, more than 5 criteria, studies have shown this correlates with people who have a history of pancreatic disease, who drink a lot. And again, if you limit yourself to calling chronic pancreatitis only in patients who have more than 5 criteria or calcifications, I don't think you will overcall chronic pancreatitis. So a lot of people are very excited about the Rosemont criteria. I was actually the second author on this paper. I think it's really a horrible paper. And I think this adds a lot of confusion. And we have to remember this was never really validated prospectively. So anyway, I don't think this is very useful clinically. I think it's much more simple to use this table that I put here that takes the Rosemont and basically makes it into either calcifications or lobulation, or 0 to 2 as no pancreatitis. Here is chronic pancreatitis, and everything in between, we have no idea what it means. Okay, just to show you divisum, if you notice that, if you can identify the ventral pancreas, this is the bile duct and this is the pancreatic duct. If you can show the pancreatic duct is leaving the ventral pancreas into the dorsal, you have excluded pancreatic divisum. So EUS can be used to do this. You should work on that in your normal cases. As we know now, for gallbladder and bile duct stones, EUS is now the gold standard, I think, for this. It's replaced ERCP as the gold standard because we can see things like sludge that ERCP can't see, and small stones that can be missed, especially in large bile ducts. Neuroendocrine tumors, this is the first major paper by Thomas Roche showing that EUS was much more sensitive than angiography for localizing neuroendocrine tumors. I think I would just point out that it's very important to remember that EUS is not for diagnosing neuroendocrine tumors, it's for localizing them. So there has to be biochemical proof of hypersecretion of something where you're basically ready to go to the operating room, but you want to find the tumor. You don't want to be doing people who have slightly low blood sugar and fainting spells. then you're going to start finding things. They have to have a proven evidence, for example, of an insulinoma, not just sort of funny symptoms. And if you do that, you'll avoid overdoing EUS in this situation. CT negative jaundice, and I have to move on here because I'm going to get in trouble. So this is basically the liver patient. So you can do endoscopy for varices. You can look for signs of early signs of cirrhosis. You can obviously, the big question is, are there bile duct stones? It's safe, and at the same time, you can do a liver biopsy, and I think this is going to be a major indication for EUS. Okay, so CT positive pancreatitis is what we see the most, I think, is basically whenever the CT shows masses, nodes, signs of strictures or obstruction. Remember, these nodes can also be from other diseases like lymphoma, unexplained dilation of the bile duct and or pancreatic duct, obstructive jaundice with or without a mass, cystic lesions, suspected cancer and calcific pancreatitis, and suspected autoimmune pancreatitis. These are all, I think, very common and good indications for EUS. Just remember that when you see a mass on EUS, if this is the pancreatic duct, here's a stricture and upstream dilation. A lot of this can be pancreatitis, and the actual cancer can be actually quite a small focus. And I think if you focus your biopsies on where the stricture is, and especially in cases where you don't see a mass, just always focus on the stricture, you will increase the yield of your biopsies. I would also recommend that in cases where there's signs of jaundice, biliary obstruction, but there's no mass on CT, I strongly recommend you do the EUS before the ERCP, because there may be a very small stricture, and if you put in a stent during ERCP, that can make it very hard to diagnose a small, for example, cholangiocarcinoma once there's a stent in place. Cystic lesions, so this is a huge subject which to me generates a lot of controversy. I'm not sure I want to get too much into the details about this. Cysts really freak people out, but most cysts really don't do anything. They're very slow growing. The problem is we don't have a lot of data on the conservative management of cysts because people keep imaging them all the time. But I would say that the good thing about EUS is that in certain situations, the EUS image can provide really a diagnosis just on the imaging alone. So we're talking about microcystic adenomas, IPMNs, especially when they're obvious IPMNs, and pseudocysts with a reasonable clinical history. We personally needle very few cysts compared to most people, less than 10%. Basically all cysts less than 2 centimeters, we just tell people to do an MRI and follow them that way, and only do an EUS if they're 2 centimeters or more. And then once we do the EUS, then this helps us stratify what to do with those lesions. The Japanese tend to like looking at things. They look a lot at things. They think they're very good. Maybe they're good, but if you try and use these type of classifications in North America, they don't work, and there's data to show that. So I think really we're not very good at just looking at cystic lesions, except, as I say, in these pathognomonic appearances like microcystic adenomas, obvious IPMNs with wide mouth communications of side branch lesions with the main pancreatic duct, and where you see these really, we can look at these mural nodules, and especially if you see mucus coming out of the papilla. I think we can really be certain then we have a diagnosis. And then obviously, certain cystic lesions in the history, when the history is very consistent with acute pancreatitis, cysts that weren't there that have appeared, I think we're pretty good at diagnosing pseudocysts. Cyst fluid analysis, I don't want to get too much into this. I find that a lot of times it adds more confusion than anything else, and I think there will be other talks on this. Just remember that there are risks to cyst fluid analysis, and I think one of the biggest risks, besides the bleeding and infection, is that it just causes confusion. So I think you should maybe avoid those if possible. I'm going to skip these slides. But the biggest questions I have for cyst fluid analysis then, does it really change management? Because actually improve outcomes? And if you do change management with using cyst fluid analysis, does it actually improve outcomes? For example, survival. Like, does removing a slowly growing dysplastic lesion really help? If you're 75 years old and you have a dysplastic cystic lesion, is that cystic lesion really going to take your life, or are you going to die from something else? And how does it affect quality of life? Are we just worrying a lot of people for nothing? So if you take, the fact that we have an unclear diagnosis in many cases, and we combine that with unclear outcomes, you can imagine what kind of benefit we're doing for our patients. So I almost wonder to some extent if having too much information on these cysts actually is unhelpful, because it makes us do all kinds of strange tests and risky tests and follow-up tests that end up just worrying people for nothing. Autoimmune pancreatitis, just to say that, you know, if it's suspected on the CT, there are some fairly obvious EUS features, but I think the biggest thing now is that with the new cutting needles, and I distinguish cutting needles from bevel needles and FNA needles, with the new cutting needles, we can actually get adequate tissue now to diagnose autoimmune pancreatitis. And you can also use EUS after you treat autoimmune pancreatitis to see if it responds well. The pancreas tends to deflate, and if there were strictures, you can really see the strictures resolve with disappearance of the upstream dilation. So what are the best non-pancreatical biliary indications? I'd say some of the most frequent then for us are still submucosal tumors. I really dislike doing submucosal tumors. They're actually not as easy to do as many people think, and sometimes I find that the results are very, very unsatisfying. Suspected Linitis is for us a common clinical problem, and again here, getting the biopsies with these cutting needles is finally successful. Indeterminate luminal strictures, okay, I think is an excellent indication for EUS. It's not perfect, but it's not bad. Liver disease is a whole subject that I'll get into in a sec. And again, incontinence and fistulas. So I don't want to give you much on this, but we do quite a lot of these. And for incontinence, certainly the EUS of the anal sphincters appears to be useful because they keep sending us patients for it. So I'm assuming we're fairly accurate as well. And I think it's easier and faster to get, certainly in Canada, than an MRI. And for fistulas, too, it appears that I think we're actually not bad. They send us a lot of these cases, too. I think it might be an issue, again, with access to MRI. I think in complex fistulas, MRI may be better. But just as a quick test to look for a fistula or for a perianal abscess, I think EUS is really a good test. So for SMTs, what's the goal of EUS? You want to find out, is it actually a lesion in the wall or not? Then you want it, this is the way I look at it, is it hyperechoic or not? If it's hyperechoic, then it's pretty much probably a lipoma. If it's not, then it's something else. Then is it in the mucosa or is it in the fourth layer? Okay. If it's in the mucosa and it's small enough, then can you take it out? If you really want a firm diagnosis, can you do an EMR? If it's really huge, you can't do an EMR. If it's smaller, I think the next step is EMR. And if it's in the fourth layer, then, well, we don't do that kind of stuff. But I think most people would not want to do fourth layer lesions endoscopically. And then whether you sample it or not. My phone is ringing here, sorry. And then after you've got all that, do you watch it or do you ignore it? Or do you remove it? So when do we sample cystic SMTs? Only if it will change management. It has to be a surgical candidate. If it's hypoechoic, if it's Doppler negative, and if it's in the third layer and too big for EMR. The only caveat, and then obviously fourth layer lesions, if they're more than 2 centimeters, say. I would just add that we've seen a few lesions recently that were big, that looked like lipomas. They were sort of hyperechoic, and we biopsied them sort of to exclude a liposarcoma, but they came back as a GIST. And these are, again, with these new cutting needles that are getting tissue that we weren't able to get before. So any large submucosal lesion now that looks like a lipoma, I would recommend you sample that because they actually could be a GIST. Just suspected linitis, just to say again, that finally core biopsy in these lesions. We know that FNA doesn't work very well, but core biopsy with the new cutting needles finally seems to work quite well. For liver disease, I think there's a huge untapped potential for EUS in hepatology. It's kind of a one-stop shop for endoscopy. You know, you look at the bile duct, the liver, varices. You can do optical biopsy, sort of elastography. That needs to be validated. You can use contrast on liver lesions. You can obviously do biopsy. You can now measure pressures. You can actually very easily stick a needle in the portal vein and measure portal vein pressures directly. And there's EUS-guided therapy. I think the problem may be that there just aren't enough hepatologists who are endoscopists, but I think once they get into this, they will take this over. Okay, I'm going to skip this just for liver. We can do all kinds of tissue acquisition in liver patients. This is the transducer you stick on a 25 gauge needle that you just put the needle in the portal vein and you can actually measure the pressure in the portal vein. It was developed for something else, but it's being validated now for EUS portal pressure measurement. And there's really an excellent correlation between EUS measurements and transjugular measurements. This is what it looks like, just the needle in the portal vein. It's very close. It's very easy to put the needle in the portal vein. You can also put it in the superior vena cava. Basically, any vascular structure, you can put it in very easily. And then EUS-guided therapy. I certainly hope, I'm not into EUS-guided therapy for varices because I don't want people calling me at 3 in the morning. But apparently you can do it. I just hope people would stop doing studies on it to show it works. I think one interesting thing is EUS-guided RFA for hepatomas that aren't accessible percutaneously. I think we do. This is a very, especially in the caudate lobe, for example, EUS is very good for that. So weak GI indications in the last 3 or 4 minutes here. So EUS was originally developed for TNM staging, and I think this is actually getting to be sort of a weak indication for EUS. Thickened folds on CT, I'll show you this in a sec. Cancer of unknown origin, I'm not going to show any data, but we've done several of these. We never find anything. I don't know if anybody else is finding anything. We never find anything. If you have a dilated bile duct in a post-cholecystectomy patient with normal LFTs, you never find anything. And if you find anything, it's a coincidence. Okay, we have a paper hopefully coming out on that, but that's really, there's no need to image those patients, basically. Ulcer disease, just to say that EUS is not good at diagnosing ulcers because benign ulcers and malignant ulcers can look very aggressive on EUS. Ulcer disease diagnosis needs tissue, not just imaging, and superficial mucosal abnormalities. So this is just some data on T staging. This is actually rectal cancer showing that we tend to overstage T2 lesions. Here's some more TNM data on rectal cancer. What I want you to see here is this 80, 75, 75, 80. This applies to TNM staging in all luminal cancers, rectal, esophageal, gastric. That's my 22 minutes. I still have 3 minutes. This is not great, okay? This means you're wrong 1 in 5 times, okay? This is really not amazing, but it's better than CT, but it's still not great. But I don't know if you're finding, but for example, in esophageal cancer, everybody seems to be getting chemoradiation anyway, so I'm really not sure how the EUS is really changing anything. And we can discuss that, but my feeling is in esophageal cancer, I'm not sure it's useful. In gastric cancer, the only thing I find that EUS changes is if we find ascites, then we suggest they do laparoscopy to rule out carcinomatosis, because usually you can't biopsy the ascites because you have to go through the tumor. So I'm wondering why not just do laparoscopy in everybody, unless it's a very superficial lesion. And even the superficial lesions, if somebody is good at ESD, I don't think they need EUS to decide whether they can do an ESD. If it lifts, it lifts. If it doesn't lift, then they don't, they don't take it out. So I'm just not sure those indications where it's helping. As far as rectal cancer, the data of comparing EUS to MRI is actually quite similar. And the advantage of MRI is that they can look at the mesorectal fascia, which we can't see at EUS. So we actually don't recommend EUS for rectal cancer anymore. We recommend MRI. And then EUS after radiation therapy, this is in rectal cancer. Here's the T staging, okay, accuracy, which is below 50%. So when your accuracy is 50%, that's the same thing as flipping a coin. That's exactly the same thing. So you may as well just flip a coin, okay? And I guarantee you this applies to esophageal, rectal, any type of luminal cancer after radiation. The imaging by EUS is not accurate. Now, getting tissue may help, but the imaging is completely useless. This is a study we published many years ago in people in whom CT showed thickened folds, and they got EGD and then EUS. Basically, it showed that if your EGD is normal, which means the mucosa is normal, but also the distensibility is normal, when you do EUS after that, you never find anything. So actually, in people with thickened folds on CT, just doing an EGD is probably enough. And EUS is only warranted if the EGD shows something suspicious. So it would save you a number of EUSs. And then there's this thing I call EUS abuse, which often comes from hepatologists, by the way, where they send us these little things that are obviously, mucosal lesions, and they want to make sure that it's not a cancer. And it's like, well, I tell them, why don't you biopsy and you'll find out if it's a cancer or not. But things like this, other things that scare people are inflammatory polyps, because they look very scary, but they're usually pedunculated, obviously mucosal lesions, and EUS is a complete waste of time in these situations. It increases waiting time, provides basically no useful information. They're very good for training, though, because then you can have the fellows do the pancreas, because they always have like a normal pancreas. And then EUS-guided biopsy. So again, I think this is going to be the last couple slides. The benefits must outweigh the risks. Bleeding, pancreatitis, infection. Just remember that you only get complications in the situations where the indication was dubious, okay? And it's very sad, for example, in an obvious, for example, body cancer, where there is a risk of tumor seeding, to biopsy that, cause pancreatitis, and then that prevents surgery or retards surgery, okay? Tumor seeding is an issue, as I say, in body cancer, and in GIST. You've got to be careful when you sample GIST. It can be very hard to get into them, and if you go into the peritoneum, you can see the peritoneum, and it should improve clinical outcomes. For example, avoiding surgery in non-surgically treatable disease. So I personally believe that all pancreatic masses should get a biopsy, because some of them are autoimmune pancreatitis. And I don't see the disadvantage of waiting a few days to get an EUS biopsy in those patients. And then just finally, I was a big time into FNA and doing a cell block, to sort of saying you don't really need a core biopsy. But since we have these, I say these cutting needles, okay, the amount of tissue we're getting is ridiculous, okay? This is one pass, okay? There's no blood. This is all core tissue. I mean, it's so much core tissue you can't even do cytology because it's too thick, okay? And with these needles now, we're getting, better results than cytology for sure, okay? Even in this is a study of ours, in difficult cases where FNA usually fails, and we use these needles, and we got a diagnosis like 92% of the time, in cases where we were getting about 50%, okay? And there's unforeseen benefits in that even if there's no cancer, you're getting a diagnosis of a benign disease like chronic pancreatitis or autoimmune pancreatitis, which actually can help prevent further testing. We get surprise positive cases we've been following for years, all of a sudden come back as low-grade IPMN. And then you get a true pathology report with actual markers, a whole list of stuff that you would get like a regular pathology report. And then therapy, I think I'll let somebody else talk about this, but we are definitely coming into our own with specialized devices that I think are letting people who aren't, one of the 5 people in the world who can do all these guide wire things, can actually do some very good things with fairly simple devices like the Axios delivery system. And I'll stop there. Thanks for your attention.